Well, thank you guys for having me. It's an honor to be here and talking about a kind of new topic, and obviously not a lot out there in terms of history with the robotics, but it's been something that's been pretty widely adapted, and I've definitely tried to add it into my practice as well. So, thanks again for having me. So again, there's some potential benefits of robotics. If you listen to all the companies trying to sell these to you, they will tell you that they're the best thing in the world. And, there are some advantages, but there are also some disadvantages. And really figuring out in that kind of risk-benefit analysis, whether it's going to be important for you in your practice or if it's even accessible, how to use it and use it safely. There are a few publications that have come out in the past few years, and we'll review those and talk about a kind of trauma-adjacent case. Robotics and spine surgery, the studies that you read will tell you that the accuracy is wildly better than us as humans, whether that's a freehand or a fluoro-assisted technique. But I think we do have to take that with a grain of salt, that a lot of the people that are publishing these studies are the people who develop these systems, and they're very familiar with it. And you're not seeing those first few cases on the learning curve. You're really seeing people that are experts in this technology. So yes, when used appropriately, they are very, very accurate. Potential time saving in difficult anatomy, and also, radiation exposure, I think, is an important thing to consider. We have to consider the radiation to our patients and ourselves, and I do think that is something when we look at our careers, trying to reduce radiation exposure is definitely worthwhile. One of the things that I've found very helpful about the robot is, planning those precise trajectories, whether it's for passing rods or, doing a reduction of a fracture, which I have not tried, but I will show you something a little bit later where they are able to use that for, fracture reduction in addition to just getting a very precise screw placement. Some of the things that we, should consider, the cost is, very prohibitive for a lot of hospital systems. I know we had tried to get robotics here for probably 5 years before we were able to really justify the cost to the system. And so that's always something to consider. And it's not just the upfront cost of the robot. There are additional costs with the every single case and the disposables. So those are things to consider as well. Again, if you have someone who's very dedicated, there can be a fairly short learning curve. And if you use this for every case, that's wonderful. But for people that don't use it all the time and you don't have your OR staff constantly using the robotic platform, it really can present significant delays. And, here as a teaching center, I do also consider, learning. If you're coming from a location where every single screw you place is robotic or navigated, we really worry about the foundations of screw placement. And again, maybe not a concern in a private practice setting, but in any educational setting, I do think that's something we should all be looking at pretty closely. The trauma setting, we kind of briefly touched on this with our last talk, but the instability of the spine really has to change how you use this. So if just thinking, we'll go over a little bit in terms of how to think of this, but if you have the DRB or the array directly on the vertebra that you're addressing, it's going to be very accurate. If you're doing a long construct, that's not really feasible to move it each time. It is possible, but it's going to add significant time to the surgery. So if you're, even if you're moving not across the fracture site, which I definitely wouldn't recommend, but towards the fracture site, that is going to reduce the accuracy with every level you move away from the DRB. And again, a neurologic injury, time is of the essence. If you're having to bring in specific people to run the robot, waiting for additional scans to make sure it's compatible with your robotic platform. Is that in the patient's best interest? Again, things that should pretty strongly consider before deciding to use them. So this was a study case series where, again, these are all fairly small studies, but just 14 cases and 126 screws, primarily in the thoracic spine. They reported a less than 1% pedicle breach with just one medial. I think there is some limitations in this study because they really plan these in-out-in trajectories. We'll take a look at one of their images. But this just gives you an idea of, through these first 15 cases that they showed, there is, a significant learning curve, and you can see the variability where you kind of have that outlier up, towards the end where, that case took longer than even the very first case they did. So if you're getting into a situation where you're having trouble registering, it can add significant time. If you're committed to it, it is definitely possible to work around those, but this just shows not just that the time will improve as you become more familiar, but there can be outliers that are significantly adding to your OR time. And this just shows kind of the highlighted outlines of the pedicles. In this series, they were kind of very judicious using this as a plan. So they did not consider this a pedicle breach because it was not medial. Some people, I think, would try a more direct approach to those pedicles as opposed to just choosing an in-out-in approach. So again, that is this 1% misplacement, I think, has a very kind of lax criteria. So always important to look at when you're looking at the cases that are presented. Again, another case series, 42 patients, a little bit larger cohort here. They're reporting 100% accuracy. And many of these cases are, MIS techniques. And again, if you're looking at a patient who has a neurologic injury that needs a decompression, some of the soft tissue management can be a challenge with robotics. And again, they're choosing these cases specifically because they are probably more amenable to a robotic or an MIS platform. So again, just things to consider when you're looking at these. And I thought this was an interesting demonstration. If you look here at at that level where the screw is going up through the end plate, that's actually an attempt to reduce this ankylosing spondylitis and get a fracture across the fracture plane. Again, if I was doing this using freehand or fluoro, I probably would not even attempt that. Whereas you can see after the reduction and stabilization, they were actually able to get two of those screws across the fracture, which is, again, one of the advantages that I probably wouldn't have, even attempted had I not had the technology of the preoperative planning. This is the third study we'll look at, and this is an interesting one because they're using the hybrid OR suite, using this for pelvic X-fix, acetabular fixation, and iliosacral screws in addition to spine surgery. And this is a much larger series out of Germany, and they graded it at 20 or just 2% missed accuracy, and these are, just over 2 millimeters of divergence from the plan. So really very accurate if you're using that criteria. But again, 2/3 of them were MIS cases, and they actually did this in the cervical spine as well. And I think, this is something that I would be a little bit nervous to implement the, pedicle screw in the subaxial spine because of the vertebral artery. In the setting of trauma where we have an unstable spine, I think the cervical spine can be unstable as well. It really takes a lot of precision in the technique. But they found that with the use of this system in their 210 patients, very good accuracy. And again, some addition to time, but overall their times were fairly good. I want to say on average, they were under 2 hours for this case series. But again, that's all comers, putting an iliosacral screw is going to bring down that time significantly, as opposed to a multi-level construct where you're doing a long pedicle screw fixation. So as we talked about briefly before, the considerations here are, if we're looking at a fracture, you are always going to want to have your registration be very close to either end, so you can use two separate registrations I would recommend for an unstable fracture. Whether you want to use that on, with the image guidance system, there are opportunities. Sometimes you may have two, and you can actually place one at the head of the patient, one at the foot of the patient. That would be one approach. Or you can do two separate arrays with just one viewer. And again, where the array goes is critical here. And so I'll show you one case where I use it mostly just for pelvic fixation. But if you're placing this array on, for instance, the posterior superior iliac spine, you're going to have very good accuracy with your pelvic fixation and those first few levels as you work away from it. If you cross the fracture site, the accuracy of those screws is going to be very low. And the motion is all, where the arrow is placed here, the motion is all there. So as you approach that arrow, your accuracy will go down significantly. So if you have very small pedicles and challenging anatomy, I recommend moving that DRB closer and re-registering. If you have, ample size pedicles and you're less worried about the accuracy, you may need to do less separate registrations. And also considering, where the camera is, so where the eyes are in relation. If it's just on the bottom, how is that going to affect the field? So again, if you, as you mentioned earlier, treating this as two separate cases, having the DRB above and below, doing a separate registration for each. I would definitely recommend if you're doing in the trauma setting. It's very easy to get confident with this in a degenerative setting where you have a rigid spine and not anticipate this, and that can lead to significant malposition of your screws. So I just wanted to go through this case where, again, this is kind of a oncologic burst fracture where I was able to use the robot pretty successfully. And again, this is a tumor case, a young gentleman who had pretty significant weakness and paresthesias over the course of the week. So we did a pretty wide tumor resection. So this is me placing the array. I think you can't discount the live fluoro. So those screws above the fracture, pretty good anatomy. Using a live fluoroscopic view is going to give you real-time imaging as opposed to registration with a image guidance system that's just one snapshot in time that can be altered if the anatomy is altered. So we put most of our screws just with normal fluoroscopy, but I really felt like getting a nicely planned 4 pelvic screws with 2 S2AI screws and 2 modified iliac screws was really going to give this patient a lot more stability. And so you can see here how we were able to plan those screws in 2 different trajectories and not get any interference of the screws and get kind of maximum purchase. And I definitely don't think my accuracy would have been as good doing this freehand. And, the time saved in getting these really well placed, I think definitely was valuable for me because these can be challenging if you're struggling with the anatomy. And again, this is just our final fixation. We did a corpectomy from the posterior, and those are 2 PEEK cages giving anterior support. But again, those pelvic screws are really, can be challenging, and I've found to be very helpful with the robotic platform. So just wanted to thank you again, right on time here. So thanks for having me, and happy to answer any questions.
Yeah. Yeah, Amir, thank you so much. I mean, yeah, I think those screws at the end looked phenomenal, and the fact that you could fit, multiple, two of them, both of which were incredibly long. It's just so much easier with some enabling technology.
Absolutely.
Thanks for giving such a measured talks on both the advantages and disadvantages of robotics. It's a technology for which there's a lot of excitement. So you sort of hinted at this, but like starting off, like let's say I'm not using a robot now, but if I were to start in the near future, should I start off with a trauma case, or?
Again, the case I showed, I only used it for the pelvic screws, right? So that's something where, my array was in the PSIS and I was directly next to it.
Yeah.
That's something that you could definitely do, in a trauma setting if you needed it, or, limited screws, whereas going to doing the whole construct, I think would be a stepping stone. I don't know if you do any kind of degen stuff, but it's definitely a much more stable setting, and just getting familiar with the workflow, I think, would be helpful. So you're not, doing a possibly unstable trauma patient and trying to build a new technology.
That makes sense. What implications do you have now that like a lot, you have, you're training a number of fellows. Like, what are the implications for sort of our surgical education when, in a lot of our programs, we do have a lot more of these enabling technologies, whether navigation or robotics? Like, do we still need to teach, standard freehand technique or fluoroscopically based? Like, is there still a value in that?
I absolutely think so. I mean, I, in my training, did not do any navigation or robotics. One of my partners needed to be able to place DBS leads, and we got an O-arm a few years in my practice, and that was when I first had access to it. And these systems do go awry. There have been times when I've had to bail on the system, and it's because I could see the trajectory and see that it was not what I would plan if I was doing it freehand, and that raises your awareness. You can do checks and say, hey, something has gone wrong here. If you don't have that experience to know the anatomy and feel comfortable with knowing the trajectories, then you're probably going to miss that and just keep pushing forward. So I definitely think that the basics are still crucial.
Amir, great talk. I'm very opinionated. I think you better be good at freehand, because so many times we did cases and they say, Dr. McAfee, the arm's frozen up. You're going to have to do the whole thing freehand. And unfortunately, there are people that are training now from programs, and if the robot's not working, they'll reschedule the case. And I'm not a believer in that at all. I think you have to know how to do all the surgery freehand, and you're bringing in. I look at robotics and navigation as being different, and I separate the two. I think robots, they're clunky. They can help you if you're doing the same sort of thing over and over again, but I'm a huge believer in navigation. I think every case should be navigated because it always helps to have a computer double check your work. I'm also a big believer in going outside in the upper thoracic spine. There's just too many cases where you might have a pedicle that's 4 millimeters, and yet the smallest screw is 4.5 millimeters. So if you start going down the center of the pedicle, you're going to work towards the canal. So we navigate off of the medial wall of the pedicle and treat the costovertebral joint as the pedicle. And so it means the GERD spine classification wouldn't be accurate because you're intentionally not going down the middle of the pedicle. Also, think about this for a trauma case. If you're doing a thoracic pedicle screw, you often have to have the anesthesiologist hold the respirations, because just by expansion of the chest, you're moving 3 or 4 millimeters, and that'll knock you right into the canal or out of the desired location. I didn't like the case you showed of the ankylosing spondylitis. I think you got to reduce that posturally on the table or with screws in the upper and lower segment. To me, it looked like the screw was an interference screw across the fracture site, and it's not going to hold anyways. I wouldn't have any part of that kind of thing. Now, here's another thing to think about. It's so, you look at movement as your enemy. From the minute you do, you're exactly right. There's no such thing as real-time registration right now. For real-time registration, you have to go to electromagnetic navigation or your fiber optic shape sensing, and it's not available for spine. For years, the companies did not offer you a DRB to be attached to a screw. You want a monoaxial screw, but they'd either give you a spinous process clamp or a iliac crest clamp. And to me, you're exactly right. If you want the DRB to be on the same vertebrae you're working on for maximum accuracy. And it looked like your judge of accuracy was, well, what it should be is your planned trajectory versus where the screw ends up. And 2 millimeters might not be accurate enough, as a matter of fact. And then the last thing is, if you want to be convinced about robotics and navigation, just do S2 AI screws, because it makes it so much easier. It means you're not taking 6 or 7 shots with a C-arm tech and they're trying to show you, the teardrop. It's so much more straightforward if you use it with robotics. You'll be convinced. And then the other one is, you showed some really good cases. It's too bad Dom Cork had to retire, but he had the best series of cervical navigation. And for cervical navigation, you're coming way in from the side to get the right trajectory down the pedicle and miss the vertebral artery. And for that, you do not want to use a midline skin incision. It'll be just too wide an exposure. So he would do it percutaneously, and he had a really good series going. And I haven't seen anybody else with that. But that's a problem. The cervical spine's so mobile, it's a real problem where you put the DRB. But I found it tremendously helpful. It's at C1, C2, and also C7 and T1. It's a great talk. You're right. We all need bigger numbers for trauma.
Yeah.
I think there's a great application in the future, but you need real-time registration, because every minute that goes by, every little thing that happens where the patient moves, you're going to have complications.
Absolutely. Great points. Thank you.
Yeah. Thank you so much for your comments. Any questions from the audience? Or?
Yeah, I had a couple comments. We've used robot for 10 years, and I was just curious how much time you think it added to your case. First question.
So in this case, probably not that much, because this platform we're using, the Globus, and you have to register each segment individually. So if you're doing a very long construct, you have to do a lot of fluoro. You have to get the right shot. You have to merge it with your pre-op scan. With this one, it was really just S1 in the pelvis. So that's 2 shots, and really did not add a lot of time. I want to say on the order of less than 10 minutes. I
really agree with Paul. Is that I probably would tend to not be too interested in using a robot because of the instability of the spine. It's constantly moving, and you're losing registration, and you just need to get it stabilized as fast as you can. Even if you just do a temporary rod, that dramatically improves your registration of your guidance, that you would be using your X-ray interoperative guidance and everything, so I just worry that it adds a lot of time, and you lose a lot of reference. And every one of those spins you do, when you talked about radiation, like an APN lateral lumbar spine is 2.5 millisieves, about a millisieve apiece. And how many times you do that, all of a sudden you're up to 4, 5, 6 millisieves. Well, shoot, you can do a O-arm spin is 4.3 on low settings. So the radiation, you got to know how much radiation you're pouring into a patient when you're doing these tests. And if you lose your registration with a robot 2, 3, 4 times and have to respin intraoperatively, you're 10, 12, 14 millisieves. You're up to getting a cardiac cath. And so it's important to know how much radiation. EOS. Most people don't even know that a whole body scan is only 0.7 to 0.9 millisieves. versus scanning, doing regular X-rays on that would be 6 millisieverts by taking conventional digital X-rays. So know how much those devices throw into people. And the robot, it just loses registration so easily. We have a lot of skives on it and everything, and so that's why I'm a little cautious about it.
I'll just reinforce what John said. Absolutely right. I studied 100 cases at MedStar while we were doing the registration using pre-op CTs versus the E3D, where you do this actual spin might take 2 or 3 minutes, but everybody's leaving the operating room, but the patient's getting the radiation. And I go to the Navigation and Robotics Institute meeting every year. And there were some people that were doing as many as 5 spins in a patient. That's just way too much radiation. And so to answer John's original question, when I studied 100 cases before and 100 cases after, they were all analyzed at arm's length by neurosurgery residents. And we actually saved 45 minutes, average of 45 minutes, by doing the E3D and having the automatic registration. And now it's going to be called Excelsius IQ, which is going to be automatic planning. The surgeon will fine tune it, but it'll be all done automatically by computer. So that's going to help a lot of time. See, part of the problem is if you do a preoperative, you have to plan it out ahead of time. You have a preoperative CT, then you plan everything with all your screws. Now at surgery, you do an E3D and you get a scan. There's no way to merge those two. So it means at surgery, if you're the only surgeon, you're going to be breaking scrub and planning every screw. So that's why I'm a big believer in co-surgeon. So while I'm operating, concentrating on the patient, my co-surgeon can do the planning and vice versa. So I think that there'll be a role in the future for the navigation, but you both pointed out the challenges right now. And, I think robotics I look at is separate. The navigation's good, but the robotics, we're not there yet for really tough trauma cases. And I wouldn't do it as my first case.
Thank you. Well, thanks, thanks, Amir, for the
Of course.
for the wonderful talk, and thank you, Drs. Dymar and McAfee, for some insightful comments. Now it's my pleasure to introduce David Gendelberg, who will give us a talk on the use of enabling technologies for